Hello, this is the Unit 4, Module 12, Chapter 23A presentation. The big picture topics for this first half of Chapter 23 include the anatomy, physiology, and ecology of wounds, and a discussion of the common bacterial infections of those wounds. In 1891, Clostridium tetani was isolated from a human victim by Kitasato Shibasaburo, who later showed that the organism could produce disease when it was injected into animals, and that the toxin that Clostridium tetani produced could be neutralized by specific antibodies. Various factors contribute to the probability of a wound becoming infected. The contaminating dose of a microorganism and its virulence can be critical. Other things being equal, the chance of infection increases progressively with an increasing contaminating dose. The physical and physiologic condition of the wound also influences the likelihood of infection. Areas of necrosis, hematomas, excessive edema, poor blood supply, and poor oxygenation all compromise the normal defense mechanisms and substantially reduce the dose of organisms that are needed to create an infection. Open injuries have a potential for serious bacterial wound infections. Wounds break the continuity of the skin and allow organisms to gain access to tissues. Agents that inflict wounds can be grouped together by the depth of the wound and by the likelihood that they will serve as carriers for organisms that will cause infection. Wound infections may occur as a result of penetrating trauma from plants, animals, guns, knives, or other objects. Various plant products can puncture the skin and result in a wound infection. Because plants are generally made of porous materials, a thorn or other such object can serve as a vehicle for the entry of other organisms into the tissues. There are various wound types. Incisions or cuts are wounds that are made by sharp cutting instruments such as knives, razors, and broken glass. Punctures are caused by objects that penetrate into the tissue while leaving a very small surface opening, for example, nails, needles, and wire. Lacerations are injuries where tissue is cut or torn. Contusions are injuries that result from a forceful blow to the skin and soft tissue, but leave the outer layer of skin intact. Abrasions are injuries where a superficial layer of tissue is removed, as is seen with first-degree burns. Gunshot wounds refer to a form of physical trauma sustained from the discharge of arms or munitions. And burns are a type of injury to flesh or skin that is caused by heat, electricity, chemicals, friction, or radiation. Wounds open and expose normally protected interior tissues. After an injury that causes a break in the skin or after an operation, various wound infections may occur. The wound may become red, tender, painful, or produce pus. Wound healing occurs in a four-step process. The first step is hemostasis. The wound clots to prevent blood flow. Step 2 in wound healing is the inflammatory phase, where debris and bacteria are removed. Step 3 of wound healing is the proliferative phase, where collagen is deposited, new tissue begins to form, and the wound starts to contract. The final step of wound healing is contraction, where myofibroblasts attach to each side of the wound and contract, shrinking it and completing the healing process. An abscess forms when an infected wound heals over on the surface, sealing the infection inside. Fever is generated as the infection incubates. Diseased tissue and the inflammatory cells liquefy into pus, which breaks through the overlying surface skin and drains. This can lead to a foul odor, pain, and discharge. The area may or may not heal on its own. When bacteria are introduced into the body via a wound, the immune system tries to fight the infection by sending white blood cells to the affected area. As the white blood cells attempt to phagocytize the bacteria, it causes inflammation and the death of nearby tissue, leading to the formation of a cavity. The cavity fills with pus to form the abscess. The pus contains a mixture of dead tissue, white blood cells, and bacteria. The abscess may get larger and more painful as the infection continues and more pus is produced. Traumatic wounds can introduce microbes deep in the tissues into areas that allow anaerobic growth. Traumatic wounds comprise such diverse damage as deep cuts, compound fractures, frostbite necrosis, and thermal burns. The sources of infection to traumatic wounds can include, number 1, the patient's own normal flora. Number 2, material from infected individuals or carriers that may reach the wound on fomites, hands, or through the air. And number 3, pathogens from the environment that can contaminate the wound through soil, clothing, and other foreign material. Examples of such infections include contamination of a penetrating stab wound to the abdomen by colonic flora, contamination of a clean surgical wound in the operating room with Staphylococcus aureus from the flora of a perennial carrier, and the introduction of spores of Clostridium tetani into the tissues, for example, on a splinter. The removal of necrotic tissue and the surgeon's skill, gentleness, and attention to detail are major factors in preventing the development of infection. Staphylococcus aureus remains the single most common cause of infection of clean surgical wounds. Staphylococcus aureus causes disease both by producing toxins and by inducing pyogenic inflammation. Toxic shock syndrome toxin, TSST, causes toxic shock in individuals with wound infections of Staphylococcus aureus. TSST is produced locally by Staph aureus in the vagina, nose, or other infected site. TSST toxin enters the bloodstream, causing a toxemia. TSST is also a superantigen and causes toxic shock by stimulating the release of large amounts of interleukin-1, interleukin-2, and tumor necrosis factor. Recall that staphylococci are spherical gram-positive cocci arranged in irregular grape-like clusters. All staphylococci produce catalase, whereas no streptococci do. Remember that catalase degrades hydrogen peroxide into oxygen and water. Catalase is an important virulence factor because peroxide is microbicidal, and its degradation limits the ability of neutrophils to kill staphylococci. The staphylococcal wall can initiate an inflammatory response that includes the sepsis syndrome. Staphylococcal toxin, which causes pore formation in various eukaryotic cells, can also initiate an inflammatory response with findings suggestive of sepsis. Following introduction into the wound and colonization, Staphylococci replicate at the initial site of infection, elaborating enzymes that include serine proteases, hyaluronidases, thermonucleases, and lipases. These enzymes facilitate bacterial survival and local spread across tissue surfaces. The Staphylococcus aureus toxin PV leukocidin is cytolytic to macrophages and monocytes. Staphylococcus epidermidis does not produce exotoxins, thus it's incapable of causing either food poisoning or toxic shock syndrome. Staphylococcus epidermidis, however, does cause pyogenic infections. It is a prominent cause of pyogenic infections on prosthetic implants such as heart valves and hip joints. Staphylococcus epidermidis is part of the normal human flora on the skin and mucous membranes, but it can enter the bloodstream, causing bacteremia, and it can cause metastatic infections, especially at the site of implants. There is no vaccine against the staphylococci. Cleanliness, frequent hand washing, and aseptic management of lesions help to control the spread of Staphylococcus aureus. Persistent colonization of the nose by Staph aureus can be reduced by the use of intranasal mupirocin or by oral antibiotics, but it's very difficult to eliminate completely. People who shed Staphylococcus aureus may have to be removed from high-risk areas, for example, if they work in operating rooms or if they work in the newborn nursery. Severe invasive group A streptococcal infections with the toxic shock syndrome often begin with a simple skin or wound infection. The streptococci are spherical gram-positive cocci arranged in chains or pairs. All streptococci are catalase negative, whereas staphylococci are catalase positive. The M protein is the most important virulence factor, and it determines the type of group A hemolytic streptococci. M protein protrudes from the outer surface of the cell and it interferes with ingestion by phagocytes. In other words, it's antiphagocytic. Beta hemolytic streptococci form a clear zone around their colonies because they're able to completely lyse the red blood cells when they're grown on sheep's blood agar. Hemolysis is due to the production of enzymes, hemolysins, called streptolysin O and streptolysin S. The pathogenesis of streptococci include its release of protein F, which is also involved primarily in adherence to antigen-presenting Langerhans cells. Streptokinase causes dissolving of fibrin in blood clots. Hyaluronidase can degrade hyaluronic acid, which is the ground substance of subcutaneous tissue. Hyaluronidase enzyme is known as the spreading factor because it facilitates the rapid spread of Streptococcus pyogenes in wound infections. DNase degrades DNA in exudates or necrotic tissue. As I mentioned in the previous slide, streptolysin causes lysis of red blood cells, and the M protein of Streptococcus pyogenes is its most important antiphagocytic factor, but its capsule, composed of hyaluronic acid, is also phagocytic. The risk factors for necrotizing fasciitis include the following: diabetes, chronic disease, if you are immunosuppressed, if you are an intravenous drug user, if you have peripheral vascular disease, renal failure, or some other type of underlying malignancy. There are no vaccines available against any of the streptococci except Streptococcus pneumoniae. Pseudomonas aeruginosa causes primarily infection in patients with lowered host defenses. Pseudomonas aeruginosa can cause infection virtually anywhere in the body, but urinary tract infections, pneumonia, especially in cystic fibrosis patients, and wound infections, especially burns, predominate. Pseudomonas aeruginosa grows as a non-lactose fermenting colony on MacConkey or EMB agar. It's oxidase positive and it is a strict aerobe. Pseudomonads are able to grow in water containing only traces of nutrients, for example in tap water. Pseudomonas aeruginosa has a remarkable ability to withstand disinfectants, which accounts in part for its role in hospital-acquired infections. Pseudomonas has been found growing in hexachlorophene-containing soap solutions, in antiseptics, and in containers of detergent. The pathogenesis of Pseudomonas is based on multiple virulence factors: endotoxin, exotoxins, and enzymes. The Pseudomonas endotoxin, like that of other gram-negative bacteria, causes the symptoms of sepsis and septic shock. Its exotoxin A causes tissue necrosis. It inhibits eukaryotic protein synthesis by the same mechanism as diphtheria exotoxin, namely using an ADP ribosylation of elongation factor 2. It also produces enzymes such as elastase and proteases, which are histotoxic and help Pseudomonas to invade the bloodstream. Pseudomonas also makes piocyanin, and this damages the cilia and mucosal cells of the respiratory tract. Pseudomonas aeruginosa is primarily an opportunistic pathogen, causing infection in hospitalized patients, especially burn victims, in whom the skin host defenses are destroyed. In those with chronic respiratory disease, for example cystic fibrosis, in whom the normal clearance mechanisms are impaired. Pseudomonas can cause infection in those who are immunosuppressed and in those with indwelling catheters. Pseudomonas is responsible for 10 to 20% of hospital-acquired infections, and in many hospitals, it is the most common cause of gram-negative nosocomial pneumonia. Because Pseudomonas aeruginosa is resistant to many antibiotics, the treatment must be tailored to the sensitivity of each isolate and frequently monitored. Resistant strains can emerge even during therapy. The prevention can include removing indwelling catheters promptly, taking special care of burned skin, and taking other similar measures to limit infection in patients with wounds or reduced host defenses.